Hi, I'm Dr. Christopher Juels. I'm a board-certified, fellowship-trained foot and ankle surgeon. I work at Tier 1 Orthopedics in Cookeville, Tennessee. The anterior tibial plate is going to be great for the anterior tibial plafond, comminuted fractures, and shear type fractures. It can also be utilized if there's a large posterior mal or extension of the posterior mal as well. So it does have a little bit of a couple indications for it. Typically, these are going to be your pilon fractures, AO classification type Bs for the most part. One of the biggest things for this is understanding that these are going to be higher energy injuries. So it's very important to consider the soft tissue during this and respecting it as far as if it's a high energy injury and it's a comminuted fracture or significantly displaced, you may be doing a closed reduction, may need put the patient in an external fixator or delta frame for the first 10 days to 3 weeks beforehand before coming back in and doing your definitive fixation. Definitely for preoperative planning, checking your radiographs for AP lateral and mortise views of the ankle, and getting a CT scan for your surgical planning as well. For the anterior tibial plate, there's a few ways you can dissect. You can come straight through the anterior approach. You can come more from an anterior medial approach. You can also have an anterior lateral approach. So now we will start the dissection with the straight anterior approach. I typically go straight midline and stay basically right over the extensor hallucis longus tendon, which will eventually retract. So when we come down here, you can run into the superficial peroneal nerve. So initially when you get through the skin, you'll come across there's the superficial peroneal nerve that you're looking for to retract. It's coming from lateral to medial and crosses the anterior joint. And you want to try to keep that retracted laterally as it provides sensation to the top of the foot. Next we'll come down here, get some retraction. So next you can start to see the superior extensor retinaculum. From this spot, I always like to identify the extensor hallucis longus tendon. That'll be our landmark. I try to hug just the medial aspect of it and try to avoid the tibialis anterior tendon. You can start to see the deep neurovascular bundle, the anterior tibial artery and the deep peroneal nerve will be sitting usually just deep to the extensor hallucis longus tendon. So when we get here, make sure we're getting those retracted and try to get down to periosteum before you make your next layer. Next, once I have the bundle retracted laterally, I'm going to go straight down to periosteum, and this will be kind of a periosteal and a capsular incision through the ankle joint. You'll notice sometimes there's some deeper veins in this area to make sure you're bovening when you go through. And then here you can use your periosteal elevator to help strip off of the anterior surface of the tibial plafond here, to release the periosteum off of those anterior fragments. Typically with these pilon fractures, you can have just an anterior shear, which will be kind of a bigger anterior piece in which we can just use this as mostly a buttress plate. Sometimes, and a typical pattern is you'll have an anterior medial, an anterior lateral, and then centrally you'll have a dive punch. So typically the first thing once we get down here to the fracture, so we want to mobilize these pieces, retract them out of the way, and get that dive punch back down in the articular surface. I typically backfill behind that because there's a void, almost like a calcaneal fracture. I usually graft behind that and pack it with either some DBM or bone graft of your choice. So once you get your dive punch back into position, you can put your anterior medial and anterior lateral pieces back on top and restore the articular surface. One of the biggest things is you're going to be restoring length to the joint. So sometimes if this is too contracted and it's hard to get these pieces down, having either a femoral distractor or an external distractor is sometimes necessary intraoperatively. But after we get those pieces back into place, then we start temporarily pinning those pieces with different K-wires, either a 1 millimeter or a 1 6 millimeter or smaller. So typically, after reducing, we're going to get this piece connected to a stable component in the posterior aspect of the tibial plafond. And then you can pin your anterior lateral piece. So now after you have the pieces reduced and pinned into the correct position, you take intraoperative fluoroscopy, some AP mortise and lateral views to make sure you like your reduction. And at this point, you can either throw some cannulated screws or you can go ahead with placing your anterior tibial plate. So we can slide this plate using the skived feature up the anterior surface of the tibia. This does come with an 8-hole and a 10-hole option. So if you need to get a little higher up on the tibia for stability, we typically want at least 3 screws proximal to the most proximal fracture fragment. So that may influence your length. So as soon as you get it into position, you can pin it with some olive wires or a temporary K-wire. So you see with this plate, the benefit of this is the width distally with the cluster here, where you can capture both the anterior medial and anterior lateral fragment and capture any comminution that's anteriorly. And the same thing is if you have a really bad wide posterior malleolar fragment that extends medially, same thing. You can use this posteriorly on the tibia. So with these plates, the universal holes allow for a 2-7, 3-5, and 4-0 locking and non-locking screws. Distally, when we're using more of it as a rafter, I typically would use a 2-7 screw, either locking or non-locking. And then proximally, we'd either use a 3-5 or 4-0 to help stabilize into the stronger tibia. Next, you will fixate this plate however works best for the fracture type and the deformity. If we want to temporarily pin the pieces and use this more as a buttress, the best hold to help stabilize things is the hold just proximal to the fracture site. And that will help buttress and use the wider part of the plate distally to suck the fractures posteriorly. Following drilling, we'll use our depth gauge and measure. We'll use a 3-5 cortical screw. And then we put this non-locking one in. This will help really suck that buttress plate down anteriorly and bring those fragments from anterior to posterior. And it'll also almost have an anti-glide effect as it pushes the fragment back down into place and reduces it. After you place your proximal non-locking screw, it is up to you then if you want to keep putting more proximal screws in or if you want to go to your cluster distally. And you can start putting in either 2-7 or 3-5 locking or non-locking screws. So we will work distally now. It is important when you're getting these rafter screws, checking a lateral image to make sure you are not penetrating into the tibiotalar joint. So we're going to put in a 2-7 locking. A couple key features with the screws and the interface with the plate is it is nice having the multi-lock technology. If we don't like the length of this screw, we can take it out and get a different length and put it still back into this hole, and it can still lock into the plate just fine. The screws are also dual lead screws, which is better than having a single thread lead. It can go in about twice as fast as the single lead screw, which is also a benefit for efficiency in the case. After you place your proximal non-locking screw, it is up to you then if you want to keep putting more proximal screws in or if you want to go to your cluster distally, and you can start putting in either 2.7 or 3.5 locking or non-locking screws. So we will work distally now. It is important when you're getting these rafter screws, checking a lateral image to make sure you are not penetrating into the tibio-talar joint. So we're going to put in a 2.7 locking. The other benefit of the screw plate interface is the variable angle that comes with this. It has a 60-degree cone and 30 degrees of variable angle in any direction, which is very nice for these comminuted fractures, especially if you have pieces that are in the posterior aspect that you want to angle to be able to capture appropriately and then still be able to lock into the plate itself. After we have our plate and fragments stabilized here, I can take out the temporary fixation and the olive wires. So now at this point we can go ahead and fill the rest of the holes in, or the holes appropriately to your liking, depending on the fracture, with either the 2.7, 3.5, or 4.0s. And we will do that distally first. After we have these filled in distally, we can come back up proximally, and we still need 2 more screws proximal. At this point, we can either extend our incision. You can also use a perfect circle technique to line up and do them percutaneously to avoid any excessive soft tissue damage with length of the incision. So next we'll put 2 more 3.5 non-locking proximally to help suck the plate down and stabilize. I'll put these in by hand to show off the dual lead. And then at this point, we can check our intraoperative fluoroscopy, make sure we like our placement of the hardware and like our reduction. And then we can go ahead and do any other adjunct procedure. If we have to fix the fibula or fix another piece of the fracture, we can proceed at this point. If that is the last procedure that we need to do, you can go ahead and close to surgeon preference.